Good afternoon, everyone. I will be talking about the use of MEK inhibitors in treating orbital neurofibromatosis in children. I have no financial interest. It's not moving. Yeah, I have no financial interest. So, a 19-month-old male child presented to us with right eye protrusion since the age of 2 months and was also unable to close the eyes. There was no other significant history. Systemic examination showed multiple caphylloid spots on the back, abdomen, and the trunk. Ocular examination showed right eye pulsatile proptosis, and the child resisted the occlusion of the left eye, which signified low vision in the right eye. On retinoscopy, we noted significant refractive error on the right, intraocular pressures were raised, and there was a discrepancy in the cup is to disc ratio. The imaging showed sphenoid wing dysplasia with proptosis on the right, that was on NCCT orbits, and the MRI showed diffuse orbital mass extending to the apex with the serpiginous enhancement in the retrobulbar fat and the recti muscles, along with the involvement of the fissures and the cavernous sinus. So, as per the revised criteria, the child had caphylloid spots, plexiform neurofibroma, and sphenoid dysplasia, hence was diagnosed with neurofibromatosis 1, also confirmed on genetic testing. So now such cases are very difficult to treat because of the age, extensive disease, ocular complications, and the challenging surgery because there's a huge risk of bleeding and also higher chances of regrowth. So after detailed discussion with the pediatric hemato-oncologist, we finally had a ray of hope in the form of a targeted therapy called MEK inhibitors, and the child was started on oral tremetinib, 0.5 milligram once a day during the weekdays and 0.25 milligram once a day during the weekends, along with anti-glaucoma drugs, which was topical. Close follow-up was done monthly for the first 3 months, followed by 3 monthly and then 6 monthly. During this time, we did the bloods and ocular examination. Annual checkups were done in the form of ultrasound abdomen and growth plotting. Within first 3 months of starting the treatment, there was a significant improvement in proptosis and stabilization of disease, and the child was able to close the eyes. At 8 months, there was further improvement, and the quality of life of the child improved. There was reduction in refractive error, the IOP stabilized, and there was marked difference in the cup is to disc ratio now. As we can see, it is 0.2:1. The imaging showed reduced orbital mass and proptosis and less enhancement of the orbital tissues, and the volumetric analysis showed 32% reduction in the load of the mass. Child did develop skin rashes 4 months after initiation of the therapy, but was successfully treated with oral and topical steroids along with discontinuation of drug, which was restarted after 2 weeks, and the child tolerated the full dose. So, MEK inhibitors like trametinib represent a promising option for managing pediatric orbital neurofibromatosis, offering a non-invasive approach to control the tumor growth and mitigate associated symptoms. Coming to the discussion, we all know that NF1 is a common autosomal dominant disease with 1 in 3,000 people being affected worldwide, and plexiform neurofibromas are affecting 25 to 50% of NF1 patients, and the orbital cases are affecting 10% of the children. Now, the problem with this orbital PNF is that it has a rapid growth, which causes a lot of facial disfigurement, causes visual problems, and early intervention is a must. But the complete surgical resection is not an option, as we know, and partial defulking offers cosmetically unacceptable results, and the regrowth is very common. Now, we must understand that NF1 is basically caused because of mutation in the NF1 tumor suppressor gene. And once this gene is affected, the product of this gene, that is neurofibromin, becomes non-functional. So once this is non-functional, the RAF pathway is not inhibited, so there is excessive cell growth. So we are looking for these novel therapeutic options which is going to inhibit this pathway so that the cell growth is controlled. In a lot of NF1 people worldwide, trametinib has actually helped in tumor growth and also in reducing the progression of the disfigurement. In fact, first drug of this category was selumetinib, but it is quite costly and only available in tablet form, so we cannot prescribe it in younger children. This is one of the patients where we have actually started selumetinib, and we are still waiting for the results. But we need larger follow-ups and larger sample size as well. Thank you.
Thank you. So, do you think the cupping has reduced due to this, or the timolol you used along with that?
We used it, but also there was 32% reduction in the tumor load, so that apical crowding was also significantly reduced, so that pressure effect had gone. So it was probably a secondary glaucoma that was developing in the child. So I think both the things they helped. So timolol helped during the acute phase to control the pressure, and I think even the disease load reduced. That also is
Do you
affecting
think
the
the timolol has an apoptotic effect on the tissue, because we use it for capillary hemangioma as well?
That's a very good question, ma'am. Thank you. I had that thought. But yes, it does have effect on capillary hemangioma, but we haven't studied the effect of timolol on the neurofibroma tissues. We still have to do that.
Thank
Yes.
you.